My name is Brian Slade. I'm a student of physical therapy at Regis University. Today I will be discussing my poster on the effects that different wrist positions can have on lymph tension. To give a little background on this experiment, grip strength is affected by the muscles of the wrist. The muscles of the wrist can be broken down into wrist flexors and extensors. To produce action, these muscles must cross the radiocarpal joint. And by changing the angle of this joint, you can isolate different ways of recruiting these muscles. The purpose of this lab was to analyze the relationship between length and tension by comparing the effects of changing hand grip position and wrist position on grip force and peak EMG of the flexors and extensors. My hypothesis for this experiment was if a maximum force is exerted on the diameter set to the largest grip setting, then the largest EMG for the flexors will be produced. The subjects for this experiment were 8 Doctor of Physical Therapy students of the class of 2021. These were student volunteers ranging in ages from age 22 to 35 years old, with a standard deviation of 4.85 years. The sample had an even split between male and female, with 4 males and 4 females. The inclusion criteria for this experiment were the participants had to be healthy individuals and students of physical therapy at Regis. The exclusion criteria was carpal injuries within the last 4 months that may affect their force output at different ranges of motion. We started the experiment by placing electrodes on the participant. We removed all hair from the skin and cleaned the area with alcohol pads. 4 EMGs were placed on the participant's wrist flexors, wrist extensors, bicep, and tricep. The participant was then instructed to perform a maximal grip on a dynamometer in a standard position, in a modified standard position. We modified this position by having the participant sit in a chair with his arm on a table. The grip force was recorded for the peak EMG for flexors and extensors in Excel. The participant was then instructed to perform a maximal grip on the diameter in 4 different positions. The first position, the diameter was set to the small setting, and the participant was instructed to contract. The second position, the diameter was set to the largest setting, and the participant was instructed to contract. The third position, the participant was instructed to position his arm in maximal wrist extension and instructed to contract. In the last final position, the participant was instructed to position his arm in maximal wrist flexion and contract. We took this information and put it in Excel to calculate the percent standard muscle activation. We found that the highest activation for muscle flexors was found in the shorthand grip, and we found that the lowest force produced was in the maximum wrist flexion. In Figure 1, you can see a participant performing a maximal grip testing on a diameter in the shorthand position. In Figure 2, you can see the results of our findings. We used the color green for flexors, blue for extensors, and yellow for force. You can see that in the shorthand position, the force by the flexors was larger than any of the other charts, and in the maximum wrist flexion, the force produced was the lowest. My hypothesis was not supported. This lab found that the largest percent standard muscle activation in flexors was found in the shorthand grip. This makes sense though, because studies found that active insufficiency would not allow for muscles to contract as hard as when in a neutral position. The findings of this lab are clinically relevant because physical therapists work with muscles and joints every day. Knowing the optimal position for a joint and muscle activation can lead to efficient strengthening in the clinic.